Let us study a case summary. A male child of 5 years presented with cough, respiratory distress, runny nose for 3 days. He was treated with nebulized salbutamol for last day. He had no fever. He had been suffering from recurrent respiratory distress since 3 months of age when he first experienced severe respiratory distress and was hospitalized and given nebulized therapy. He often takes nebulization therapy and getting tablet monthly cost for last 6 months. His weight is 22 kilo, 75 centile, height 115 centimeter, there is 50 centile, was conscious, well oriented, pulse 110 per minute, having no cyanosis, could talk in sentence, blood pressure 100 by 65 millimeter mercury, he had vesicular wheeze sound with long expiration with bilateral wheeze. SpO2 94% in room air. X-ray test showed hyperinflation and case translucency. This is a child on nebulization therapy. Now, what is the clinical diagnosis? The diagnosis is childhood asthma. Any child coming with cough and respiratory distress, what are the differential diagnosis? If the child is small, the diagnosis is bronchiolitis. It may be a case of pneumonia, and if older child, it is a case of asthma. We studied more than 500 children all over Bangladesh who attend hospital in one day, and we found the common respiratory tract illnesses in children. The first one is bronchiolitis, 21%, pneumonia 11.5%, and asthma 8%. Now today's session is on childhood asthma. What is asthma? Asthma is a heterogeneous disease characterized by chronic airway inflammation causing bronchial hyperresponsiveness, resulting in recurrent, reversible, variable airflow limitation, presenting as either cough, wheezing, breathlessness, or chest tightness. Now, in relation to asthma, we have to know the atopic conditions. What are the atopic conditions? The atopic conditions are disorders where there is a genetic tendency to develop immediate allergic reactions to certain substances with an exaggerated Ig-mediated immune response. The conditions are asthma, allergic rhinitis, atopic dermatitis, and allergic conjunctivitis. Now, what is allergic rhinitis? This is characterized by runny nose, blocked nose, sneezing, or nasal itching without having an attack of cold. What is atopic dermatitis? This is characterized by chronic itching, papular eruption, persisting for more than 6 months, and signs of occasional waiting. Now, what is allergic conjunctivitis? This is characterized by red eyes, itchy eyes, without having an attack of cold. Now, asthma epidemiology. The prevalence of asthma in children is 7.4%, and allergic rhinitis it is 20%, and eczema it is 6.5%. Asthma is more common in households where the people is 3 or less. And we studied first National Asthma Prevalence Study in 1999, and I found that the prevalence of asthma in adult is 5.2%, and in children it is 7.4%. Now, if you compare the prevalence of asthma in 13 to 14 years of age children worldwide, what do we see? We see that the prevalence of asthma in UK, New Zealand, Australia is very high, around 30%. And in comparison to our region, India and Bangladesh and China, it is very less. In Bangladesh, it is 7.4%. What prevalence of atopic dermatitis? You see, the prevalence of atopic dermatitis is very high in 13 to 14 years age children in Nigeria, around 40%, the highest in the world. Not much that in UK, New Zealand, Australia. And the worldwide prevalence of allergic rhinitis, it is very high. Rather, we are the champion in allergic rhinitis. It is 20%, and not high even in UK, New Zealand, and Australia. Now, the asthma triggers. There are some triggers in asthma which initiate the attack of an asthma. The infection like respiratory syncytial virus, allergen, pollen, molds, house dust mite, irritants, tobacco smoke, air pollutants, exercise, that is strenuous exercise, drugs like beta blocker and aspirin, seasonal climatic change is a variation of temperature more than 3 degrees centigrade, stress, emotion, and pregnancy and surgery. The etiology of asthma is that asthma is a genetic predisposition to type 1 hypersensitivity reaction. And childhood infection by RSV and also acute and chronic airway inflammation, bronchial hyperresponsiveness, allergen exposure like pollen, animal, dander, and indoor pollution. And these are the asthma triggers. And the pathogenesis of asthma is that asthma is an immune response to inhaled allergen. Antigen presenting cells present the allergen to T lymphocytes. T lymphocytes, that is Th2, activate the humoral immune system. Humoral immune system produces Ig antibodies against the inhaled antigens. IgE reacts with mast cells, and the different chemicals like histamine, cytokines, nicotines, and prostaglandins are released. And these, in various ways, cause the airway inflammation. This is the diametric presentation, and the antigen presenting cells, and this production of IgE that reacts with mast cells, and production of cytokines, prostaglandins, nicotines, antihistamines, and they cause bronchoconstriction and also other way causing the inflammation of the airway, which may be acute, subacute, or chronic. And the main pathology is that there is bronchoconstriction, airway wall thickening, more and thicker mucus production. These three is very important. Bronchoconstriction, airway wall thickening, more and thicker mucus production. And you see, this is the normal airway, very wide caliber in case of asthma, and this is very narrow airway and a thick airway and production of mucus. And you see a mucus expectorated by patient acute severe asthma, very thick. And the resulting clinical features are hyper responsiveness to the airways, airflow limitation, which is reversible and variable, and asthma features, cough, wheeze, dyspnea, chest tightness, and the persistent asthma. And the pathophysiology is that because of air obstruction, there is hyperinflation and alveolar hyperventilation and ventilation perfusion mismatch. And initially there is hypoxemia, and when there is carbon dioxide retention, and there is initially metabolic alkalosis followed by metabolic respiratory acidosis. Now the classification of asthma. Asthma can be classified as intermittent or persistent. When the attack of asthma 2 or less per month. This is intermittent. And the attack is more than 2, that is persistent asthma. The attack will be cough, distress, or chest tightness. And mild persistent asthma, and moderate persistent asthma, and severe persistent asthma. And this can be reflected in FEV1, lung function that we can do. Usually it cannot be done in our situation. Now there are other special variants of asthma, like seasonal asthma, exercise-induced asthma, drug-induced asthma, top variant asthma, pregnancy-induced asthma, and occupational asthma. The symptoms of childhood asthma. Recurrent respiratory distress or wheeze, which means whistling sound coming from chest. This is wheeze. And this is 3 to 5 attacks in life. Chronic cough, night cough working. Respiratory distress or wheeze following playing, exertion, or exercise. And there is concomitant allergic conditions like allergic rhinitis, conjunctivitis, eczema. Family history of asthma or other conditions may be present. The signs of asthma is that signs for respiratory distress, suprasternal, intercostal recession, chest indrawing, barrel-shaped chest in chronic condition, central trachea, apex between position, hyperresonant and percussion, vesicular breath sound, long expiration, and bilateral bronchi. There is a barrel chest in case of a child suffering from asthma for a long time. The investigation, the X-ray test mentioned earlier, and this is raised serum Ig level, peak expiratory flow rate, the variability more than 20%, pulmonary function test, reduced forced expiratory volume in 1 second, that is 80%, or normal forced vital capacity. And also the reduced FEV1 divided by forced vital capacity, that is less than 70%. And if you go for bronchospasmolysis test, there is change of FEV1 more than 200 ml or 12% increase over pre-bronchodilator level. This is X-ray showing hyperinflation and increased astrocytes. This is peak flow estimation. And this is spirometry and doing the bronchospasmolysis test. And there is problem of diagnosis of asthma in children below 5 years because the attack of asthma simulates recurrent viral bronchiolitis in children below 2 years. This group of children can't produce sputum, they can't use peak flow meter, and spirometry is not possible in this group of children. Sometimes therapeutic trial is the only way to diagnose. And we have national guideline, asthma bronchiolitis COPD, and another guideline produced by Organization Lung Health Foundation, Lung Foundation. Management of childhood asthma is that asthma medications, you have to know treatment of acute asthma, treatment of persistent asthma, follow-up, asthma education, management of concomitant diseases. Now, what are the asthma medications? The asthma medications can be grouped into 3: liver medications, controller medications, add-on controller medications. Liver medications provide quick relief of asthma symptoms and also helpful in the treatment of exercise-induced asthma. Controller medications, most effective anti-inflammatory medications for asthma, reduce symptoms, increase lung function, improve quality of life, and reduce the risk of exacerbation and death. Add-on controller medications can be considered to improve symptom control and acts as a dose reduction strategy to limit the side effects of primary therapies, that is, of high-dose corticosteroids or long-term oral corticosteroids. The liver medications are short-term inhaled beta-2 agonist, bronchodilators, SABA, examples salbutamol, terbutaline, and used through MDIs and DPIs. Low dose inhaled corticosteroid formoterol, now also in this liver group, dexamethasone formoterol or budesonide formoterol. Short acting anticholinergics like ipratropium bromide and oxytropium bromide. Control medications, inhaled corticosteroids, right? Dexamethasone, budesonide, fluticasone, propionate. Another group is inhaled corticosteroid long-acting beta-2 agonist combinations. There is fluticasone, propionate, salmeterol, which is widely available in Bangladesh. Dexamethasone, formoterol, budesonide, formoterol, and others. Now, other contraindications are leukotriene modifiers available in tablets, montelukast, dafilukast, chromones, sodium chromoglycate, and nitroprusside sodium now seldom used. Add-on controller medications are long-acting anticholinergics like tiotropium, mist inhaler, anti-IgE, omalizumab, anti-IL-5, anti-IL-5R, anti-IL-4R, systemic corticosteroids available in tablet suspension, intramuscular, or intravenous injection. Examples are prednisolone, prednisone, methylprednisolone, and hydrocortisone. These are the asthma inhalers in different forms, and these are asthma devices, spacers that needed for use in children. This is a nebulizer machine for giving nebulized solution of salbutamol. Treatment of acute asthma. Initially, you have to assess the child and go for treatment. And assessment is done through symptoms and signs. Symptoms are physical exertion, toxins, and consciousness. In mild case, the child, there is no physical exertion. In moderate, there is no exertion. In severe, there is exhausted. And mild child can talks in sentence. Moderate attack, the child can talk in phrases. In severe attack, the child only can talk in words. In mild attack, the child is conscious. In moderate attack, the child is conscious. In severe attack, the child's consciousness is altered. And because of signs, in mild attack, the wheeze is variable. In moderate, there is loud wheeze, and in severe attack, there is quiet noise. And pass rate is mild attacks less than 100 per minute. In moderate, there is 100 to 160 pulse rate per minute. And in severe attack, the heart rate is very high, more than 160 per minute. In mild attack, there is no cyanosis. Moderate attack, there may be some cyanosis. In severe attack, there is usually cyanosis. And lung function test, FEV1 is more than 60% in mild attack and 40 to 60% in moderate attack. And in severe attack, this is less than 40%. And the SpO2 in mild attack, there is normal, more than 94% saturation. In moderate, there is 90 to 94% saturation. In severe attack, there is severe hypoxemia, saturation is less than 90%. In case of acute asthma, the options of management are the child should be hospitalized for observation or may be finally admitted to ICU. You have to give oxygen inhalation initially and beta-2 agonist inhaler nebulization, nebulized ipratropium bromide subsequently, corticosteroid systemic IV or oral, and intravenous aminophylline can be given, intravenous adrenaline can be given, intravenous salbutamol, the last choice before ventilation therapy into an ICU setup. Treatment of persistent asthma is stepwise management in children below 5 years, stepwise management more than 5 years. And there are 5 steps management: step 1, step 2, step 3, step 4, and step 5. The principle of management here is that we have to start low dose inhaled corticosteroid with SABA. Presently, this is recommended. Initially, only SABA was given. and then the subsequent dose of inhaled corticosteroid increased, step 2, step 3, step 4, step 5. And other options are leukotriene receptor antagonist and leukotriene antagonist and other medication are used. And the nebulization and other delivery devices according to age. Nebulizer therapy can be given in all ages. An MDN spacer used up to 4 years of age with spacer, having mask. And MDI spacer without mask, it is up to 7 years. And MDI alone, 8 years and older. Follow up with guided self-management plan with peak flow meter or without peak flow meter, without self-assessment plan and asthma action plan. The asthma action plan is the goal of an asthma action plan is to reduce or prevent flare-ups and emergency department visits. Following a written asthma action plan, this is very helpful for a child to support the child in case of emergency. This green area, the child is okay. This yellow area indicates the child should be cautious. Red area, child needs intervention. Asthma education. In asthma education, we have to discuss about the basic facts about asthma with the parents and medications and devices and the skill of asthma medication and precautionary measures to control asthma, and rescue action in case of acute attack, and elevation of misconception about asthma and formation of asthma club. Treatment of concomitant diseases like allergic rhinitis, allergic conjunctivitis, allergic atopic dermatitis should be given along with the treatment of asthma if the child is having. Primary prevention of childhood asthma is that excessive breastfeeding reduces the attack of asthma, low salt diet, more fish and less meat, and more outdoor sports and swimming, ventilated home, change job in case of occupational asthma. Now, differential diagnosis of asthma is the viral bronchiolitis, gastric reflux disease, pulmonary tuberculosis, recurrent pneumonia, bronchiectasis, and cystic fibrosis. Natural history of asthma is that typically asthma begins in infancy, like the first case. The child suffered from severe bronchiolitis at the age of 3 months, and at that time he was hospitalized. And following that, the child had attack of severe attacks of wheeze and respiratory distress, and then the child developed asthma. A recurrent wheeze occurs in a large number of cases, like our case, and it's good news that 80% to 90% children improve by adolescent period. And persistent asthma only develops in 5% cases. Now, some questions for the students, for you students. What is asthma? What is the prevalence of asthma? What are the atopic conditions? What is allergic rhinitis? Name 5 triggers of asthma. What is the pathophysiology of asthma? Name 3 symptoms of asthma. Name 3 signs of asthma. How asthma is classified. Name 3 investigations for asthma. Why it is difficult to diagnose asthma in children. What is the management of acute asthma? How asthma is done in acute asthma. How persistent asthma is managed. What is asthma education? What is the natural history of asthma? Thanks to all.